Hello everyone. Today we are going to discuss the journal that is intravenous vitamin C in adults with sepsis in intensive care unit, the LOVIT trial. This was published in NEJM in June 2022. Vitamin C has antioxidant effects which may mitigate the tissue injury by oxidative stress during sepsis. It also used as a cofactor for catecholamine synthesis. The most important thing is that vitamin C cannot be synthesized by human and its levels are very low in critically ill patients. So this is the biological rationale behind the vitamin C and which has increased the plausibility of benefit with its supplementation in sepsis. So the hypothesis was a high dose of vitamin C may mitigate the oxidative stress and reduce the risk of death or persistent organ dysfunction from sepsis. The research question in PICO format, the population was patients treated in the ICU for sepsis with vasopressor, intervention with high dose of IV vitamin C, 50 milligram per kg per dose every 6th hourly for next 4 days. Comparator were placebo and outcome was composite of death or persistent organ dysfunction at day 28. This was a investigator initiated placebo controlled parallel group randomized control trial which took place in 35 ICUs in Canada, France and New Zealand over a period of 3 years from November 2018 to July 2021. All adult patients of age group more than 18 years who were admitted to the ICU for no longer than 24 hours with a proven or suspected infection as the main diagnosis and who were receiving a vasopressor were included into the study. Patients with a contraindication to vitamin C, such as a known G6PD deficiency or known kidney stones within the past 1 year, were excluded from the study. And other exclusion criteria were receive of open label vitamin C, expected death or withdrawal of life sustaining therapy within next 48 hours, and the pregnant patients. Interventions done with IV vitamin C bolus dose of 50 milligram per kg in a 50 ml of 5% dextrose or normal saline over a period of 30 to 60 minutes every 6th hourly for 96 hours. Control group received matching placebo infusion. All other aspects of the care, including the use of thiamine and glucocorticoids, were as per the treating clinician's judgment. Patients were followed up by telephonic interview at 6 months. So patients were randomized into 1 is to 1 ratio to receive either vitamin C or placebo. Stratification was done using permitted blocks of variables with undisclosed size. Here, patients, clinicians, trial person, and the statisticians were unaware of the trial group assignments. Coming to the trial outcomes, the primary outcome was to study the composite of death or persistent organ dysfunction on day 28. Persistent organ dysfunction involves the use of vasopressor, invasive mechanical ventilation, or use of renal replacement therapy. Secondary outcomes were a number of days without organ dysfunction in ICU up to day 28, mortality at day 28 and at 6 months, quality of life at 6 months, organ failure as assessed by SOFA score at various days, and biomarkers of global tissue dysoxia like lactate, biomarkers of inflammation and endothelial injury were also assessed at day 3 and day 7. Safety outcomes studied were incidence of stage 3 AKI, acute hemolysis, and hypoglycemia. Sample size was calculated based on a 50% risk of death or organ dysfunction in the control group and to have a 10% difference in the primary outcome. Total 385 patients were needed in each group to provide a 80% power with a two-sided type 1 error of 0.05. The sample size was later increased to include the original sample size without a COVID-19. Primary analysis was done by using intention to treat analysis to assess the superiority of vitamin C over placebo. Secondary analysis of the primary outcome was done after adjustment for pre-specified baseline characteristics using generalized estimating equations. Coming to the results, total 2,234 patients were assessed for eligibility, out of which 834 were excluded. The most common cause for exclusion being admitted to the ICU for more than 24 hours. Finally, 872 were underwent randomization into two groups, 435 into the vitamin C group and 437 into the placebo group. In the vitamin C group, finally 429 had complete follow-up at day 28, and in the placebo group, 434 patients completed the follow-up. The baseline characteristics in both the group was found to be similar. The mean age was 65. Female patients were 35% in the vitamin C group and 40% in the placebo group. The mean Apache was 24 and SOFA was 10. The primary site of infection, the most common site being the lungs, 33.8% versus 36.7%, followed by intra-abdominal infection, bloodstream infection, and skin soft tissue infection, etc. SARS-CoV-2 positive was 8.6% in the vitamin C group and 6% in the placebo group. Vitamin C level at baseline was also similar in both the group. Septic shock definition as per the Sepsis 3 guideline were met only in 59.6% in the vitamin C group and 56% in the placebo. 68.5% and 65% in the placebo group of the patients were on mechanical ventilation, and vasopressor use was 100% in both the group. Coming to the primary outcome, so at day 28, 44.5% in the vitamin C group had died or had persistent organ dysfunction as compared to 38.5% in the placebo group, with a relative risk of 1.21 with a p-value of 0.01, which is statistically significant. After adjustment for the pre-specified baseline characteristic, the risk ratio for the primary comparison was remained same, which was 1.15. And after applying the best case, worst case sensitivity analysis for one patient, the result remained the same. When the composite outcome was broken down into the individual arms, so here they found none of the individual outcome to be statistically significant. Although the day 28 mortality was 35.4% in the vitamin C group versus 31.6% in the placebo group. Secondary outcomes. So, median number of days without organ dysfunction in ICU by day 28 was less in the vitamin C group, that is 17, and 19.5 in the placebo group, but that is statistically not significant. Other outcomes like death by 6 months was also found to be similar in both the group. Quality of life and SOFA score at various days was also found to be similar in both the group. The biomarkers studied uh, on day 1 and day 3 and day 7 in both the group were found to be similar. So the biomarkers studied were lactate, interleukin 1 beta, TNF alpha, thrombomodulin and angiopoietin 2. All were similar in both the group at various days. Coming to the safety outcomes, so stage 3 AKI was found in 37.8% in the vitamin C group versus 37.9% in the placebo group, which was also not different between two groups. Other safety outcomes were also similar in both the groups. Strength of the study, this is one of the largest trial with a blinded multicentric randomized control trial with early enrollment almost within 12 hours after ICU admission. All enrollment were finished. And other important thing is that assessment of biomarkers and baseline vitamin C level were done. Some of the limitations of this study. So first one is the primary outcome studied, which was the composite of death or persistent organ dysfunction on day 28, which was found to be statistically significant. But when the that was broken down into the individual components, none of the component was found to be statistically significant. Second one is that taking mortality as a primary outcome is not one of the interest to the patients, and also it introduces loss of power to the study. They found mortality, 28-day mortality was higher in vitamin C group, which was 35% versus 31% in the placebo group, despite being all the safety outcomes which are studied similar in both the group. One of the most important outcome parameter was the use of vasopressor, but there was no information regarding time to wean off from the vasopressor support. Other limitations are septic shock definition as per the sepsis 3 criteria were not met in all the patients. The dose of vasopressor in septic shock for inclusion in the study was not protocolized. There was no definitive protocol for use of steroid. Information regarding specific pathogens and antimicrobial therapy was also not collected. Populations in is not representative of the septic patients in ICU of the low middle income country, where the incidence of sepsis and case fatality rate are higher. Information on presence of ARDS at baseline was not collected, so it remains unclear whether this subgroup had a different response to vitamin C. So the author's conclusion was in adult patients with septic shock in the ICU, intravenous vitamin C resulted in a higher risk of death or persistent organ dysfunction at day 28 than placebo.